Minister Jennifer Carter-McNeill.
Thank you, Leska and Corla, and I welcome this opportunity to update the House on the response already underway following the publication of the clinical audit into DDH surgery on children in CHI and Cappagh, published last Friday, 23rd of May. This follows on from our debate on the 29th of April, where we said that we would revisit this, and I think it's appropriate that we continue to work on these issues together over the coming months to address our shared concerns and to move to a place where we have better confidence in the clinical governance and clinical decision-making in certain parts of CHI that have presented repeated difficulties for patients. I know that parents and young people themselves will have many questions when they read the report and the findings of the report, and will lead to worry and uncertainty for them. And like many members of this House, I have met with and spoken with parents whose children had these surgeries, and I know their worry, as I know my colleagues in this House know their worry. That experience of worry for your child, of being completely in the hands of a clinician and their advice and their decisions, is one that those perhaps who have not experienced it perhaps cannot understand the depth of that concern. In that vein, can I say that I respond today and other days to all issues in CHI that we face together in this House, both as the current Minister for Health, but also as the parent of a child in the long-term care of CHI. I hope that the actions that I and we now take help in that process, though I do recognise that the volume of cases mean that it will be some time before everyone has a resolution to their satisfaction, and I'm not happy about this, but please do let me take you through the actions to be taken and the backdrop against which they are taken, where I think we will need to go together in the future. The actions that I now take, I hope, will ensure better improvements. First, implementing the clinical recommendations of the audit to prioritise patients' follow-up care. Second, establishing an independent and external expert panel to lead a retrospective review of individual cases to determine the appropriateness of the original decision-making for performing the pelvic osteotomy. And third, taking steps to strengthen governance and oversight in CHI as we move to a longer-term perspective. My immediate priority is to ensure that there is clinical follow-up and care for patients who have gone this surgery. This follow-up will be in accordance with best practice and the recommendations of the report. I know deputies already know that there has been an information line available over the weekend. This is an information signposting for parents in the first instance over the weekend, and I totally appreciate that it does not answer every question, nor can it, and in that effort to provide signposting. But what parents do need and what they will receive is letters from CHI and Cappagh about the arrangements and next steps that individually apply to them and to their child, and how they will get further information and support. I expect these letters to be accurate, personalised, and while deputies I know appreciate that I do not personally sign off on the letters, can I assure you that I have said to both of these institutions that I expect that standard to be there in relation to these letters. Recognising that the wait for the letter is difficult in itself, and I don't want parents getting wrong information of any kind. I have been informed that clinical follow-up to skeletal maturity in CHI Crumlin is already underway for 447 patients, many of whom, about 200, are almost at skeletal maturity and will likely need just one more appointment. Clinical follow-up is also underway for CHI Temple Street and Cappagh patients. These children have been identified and categorised by age. That encompasses about 1,800 children. Again, a proportion here, 392 as I understand it, are close to skeletal maturity. It is planned that a multidisciplinary team, including physiotherapists, nurse specialists and overseen by a consultant surgeon who is appropriate, will be involved in this clinical review. It's also important to recognise this transition of care for patients who require follow-up by adult services, that be agreed, and a new model of care for all children who have gone these surgeries will be implemented, generally involving review at 5, 8, 12 years post-operation. Deputies are already aware that a cross-site pre-operative surgical meeting is already in place since March 2025. We discussed that at our discussion on this in April, so that all children being discussed are discussed at this meeting before being listed for surgery by any of the services concerned. This, along with contacting parents whose child may have been impacted by this audit, were, I am told, the two recommendations that the auditor made to CHI when he provided a draft of the report in March. I am told that CHI were informed that they were the only two recommendations were available and definitely would not change pending the publication of the report. But in respect of a retrospective review, what parents will want to know, of course, is whether the surgery that their child had was clinically indicated, was appropriately clinically indicated. Patients and parents are entitled to know that, and there will be retrospective review of their case to determine the indications for surgery. Was it needed, or how was it in line with standards at the time that it was indicated? This is separate to the clinical follow-up process. It is a separate and additional process involving a panel of independent external experts who will be established for this purpose, not connected to CHI, just to be very clear. That panel will be comprised of radiologists and paediatric orthopaedic surgeons and will be chaired by an international expert. Professor Deborah McNamara, President of RCSI, has agreed to assist the HSE in establishing this expert panel. Today I brought a memo to Government to set out the high-level terms of reference for this review. The review will have the following objectives: to provide individualised case reports for each of the cases affected, to provide an overall collated report, to provide expert opinion insofar as possible on individual cases of potential implications where it was identified that a procedure was not necessary. I'll ensure that deputies have this to hand. To have due regard for the criteria set out by Mr Thomas within his report and the criteria being developed by the expert reference group. To document the final suite of criteria against which the original surgery will be assessed. And in conducting the review, the experts will be cognizant of the historic nature of the work and aware of confirmation and hindsight bias. This terms of reference cannot be finalised until the review panel is some way in place, because I want to, of course, make sure that they are comfortable with the terms of reference, but I have taken it as far as I can take it, and I need the expert panel's opinion on their own terms of reference as well, as I imagine you will understand. Obviously, parental consent to participate in the review is required, though I suspect parents will be actively seeking this review rather than us asking them to consent to it. So this will take a little time, both to bring together the panel and, of course, then to complete the reviews. This is a recommendation of the report which we received on Thursday and published on Friday. I know the deputies in this House, across the House, have criticised this not already being in place, but as I said in April, I can only go on the detail of the report as it is presented to me. I did receive this report on Thursday last week at 4 p.m. It was published in full, as I said it would be, redacting any personal information, which, as it turned out, needed not to be necessary. It was published at 1 p.m. on Friday. The terms of reference of follow-up process is now agreed by Government, and the outstanding piece is the independent experts, and I assure the House that I will move with the same pace and urgency on that matter as I have, I hope, with other matters. In relation to governance, I want to be really clear about accountability and governance response issues. It is absolutely correct, as deputies in this House have already done, to look at the systemic and structural issues that we will all discuss shortly. But I also want to take a moment to recognise that we are having these series of debates because of the decision-making of individual consultant surgeons, whom the audits and the HICWA report have said, this audit have said we're not operating in line with international practice, and whose explanations for those operations were not accepted by the auditor. In the HICWA report, we were responding to a series of decisions that a surgeon made that led them to using non-surgical springs in the bodies of small children. We have to ensure clinical governance and accountability, but I do not want our focus on that to detract from the individual decision-making and the individual accountability that is appropriate for the individual surgeons making decisions about small children. Related to this, though, on the broader governance issue, I have said a number of times that I am trying to look at this question in relation to the broader governance of CHI in a way that enables the functional continuity of CHI, both to respond to the various patient needs, the issues that we are discussing, the broader running of the paediatric system, and to move us towards opening the new hospital. And I want to make sure that we see the appropriate governance structure in place to make sure that we have clinical leads who are managing each team, as I said back in April after the publication of the HICWA report. I want to make sure that every consultant who is employed in the Irish state knows that they are not a single fiefdom, that they work within a hospital system, that they are public servants, that they are paid by the taxpayer, and that they follow rules set out by us in an appropriate governance structure. I want a culture, again, as I've said before, where people who see that are things that are clearly wrong not only can step forward and say them, but must step forward and say them, and be afforded the appropriate protections. And in that vein, I particularly want to thank the whistleblower in this context who brought this information to light, and respect the work that whistleblowers have done in this case, as they have done in other cases. I am trying, deputies, and I hope that we will work together on this, I'm sure that we will. I'm trying to undertake a transformation process in a steady way, but I don't wish that to be interpreted as ignoring the importance of any of these issues. I'm trying to manage this in a steady way. CHI was established back in 2018 in the Act to bring together 3 historic hospitals under a single roof, and there were differences and cultural problems manifesting themselves in various different ways over the period, but I think the concept of a single paediatric system is now well settled, even if sometimes some people need a little reminding. The board is an unusual construct where 4 members, as I have said to you before, 4 members are appointed by the Minister, 8 are appointed by the board itself, coming from the nominations of the old historic entities that were brought together to CHI, and the board itself appoints the chair. There have been members of the board dating back to 2018, including until recently the chair, and then there are other members, many members who have been appointed in 2025, one in 2024, and so on. So there are 2 very different sets of institutional memory and institutional experience. Deputies will be aware that in the past weeks, in April, the chair stepped down, and since then a total of 4 other members have stepped down, all of whom I believe were appointed in 2018. This morning I referenced on radio, this afternoon I referenced on radio that 3 resignations I had received this morning, but I did not reference, and of course I should have, that a 4th had stood down last week, so my apologies for my oversight in that regard. It was certainly not intentional. But I do thank them for their contribution, and I do want to just take a moment to say that we have to think about public appointments and public service generally, that we are asking these board members generally, whether it's for CHI or other entities, they are people who we are asking to serve the public interest. They are not professional clinicians, but they are people who are broadly committed to public service. And I'm not saying that by many means of excusing individual actions or so on. I'm just simply saying that it is all of our interest that people continue to perform public service, and that's why I'm trying to separate out some of the issues from the decisions of individual clinicians. These things should not be conflated. But I think it is true, and I've said this in different ways before, that it was important in the case of CHI that while the experience of the board setting up in 2018 had very, very serious and difficult work to do, I do think it's now appropriate that their experience is brought to us to a point where a refresh is appropriate. And I take the next steps now with the following purpose. I have moved immediately to strengthen governance and oversight structures at CHI and Cappagh. That will be done by the appointment of 2 members of the Health Service Executive Board to the board of CHI. I have already done that. That was before I received these additional resignations, so I now have additional vacancies that I'll reflect on. In relation to Cappagh, I have asked this HSE CEO, Bernard Gloucester, to consider the implications of the audit for Cappagh and its oversight of paediatric surgery conducted at the hospital, and the CEO has agreed to do that and respond in the coming days. At operational level, there will be a strengthening of the service level agreement between CHI and HSE to strengthen operational oversight and increased involvement and support from the Dublin Midlands Regional Executive Officer and Senior Management, and that is designed to support the new CEO, Lucy Nugent, in CHI and enable her to continue with the transformation programme that she has already begun. Ms Nugent is in post just since February. She is in the process of establishing a new executive team around her to lead this new stage for CHI in the way I think that we want to see done. She reports to the board, and she needs a functional board to be able to function. So it is in nobody's interests to move things too rapidly. There does need to be a functional board, though it is clear I do want to see it move in a particular direction, and I think my appointments to date have signalled that direction. I have, as I've referenced before, for example, on April 9th in this House, the day after the publication of the HIPAA report, I have said that I am open to looking at the governance of CHI in the round. I've said that we need to have a functional system to be able to work towards the opening of the National Children's Hospital. And I said that I'm open to looking at everything in the round, but I said at that point I wanted to receive the other 2 reports first. It is now clear, some weeks later, that we have a very different board to the one that was there, certainly when I took office, and much more importantly, when these events occurred. Secondly, I have said very clearly that I want to see the appropriate clinical governance structure. So what that means is that consultants work to a clinical governance structure from whom they take direction, to whom they are accountable. Today I met with the Attorney-General about my next steps, both in relation to the board, in relation to clinical governance structures, and in relation to broader governance issues and how CHI interfaces with the HSE, recognising that the HSE of course funds CHI, and I will take a steady approach to this, and I welcome all perspectives from members of this House about the desirable income and the steps to get there while enabling the continued function of CHI. I do want to enable Minister O'Connor to speak as well, but it is very important as well that while we are discussing the hip dysplasia issue today, I do of course want to acknowledge to the House that I need to update you regarding an internal CHI report that was covered in the media on Sunday. The internal CHI report was provided by CHI to the HSE CEO on Monday the 26th of May, and I received a copy from the HSE yesterday, on Monday the 26th of May. Yesterday evening, I wrote to the board of CHI requesting a full response to the report. I wrote a detailed letter asking specific questions, and I reserve my right to write further letters. I do need to now receive this response, but on receipt of that response, my officials will follow up to address outstanding risks and concerns where they still exist. In addition, the HSE CEO is commissioning an audit of governance and equity in patient access and waiting list management at CHI. The audit aims to assess governance and equity in access to care, especially regarding the balance between public and private patient management. And I will consider further responses to these issues around waiting list management and the NTPF raised in the report, and I have asked the NTPF for their perspective as well. We are also mandating centralised referral to all CHI surgical services so that all GP referrals will be processed by a central system, enhancing transparency, equity and efficiency with the aim of ensuring patients are cared for based on clinical need and to increase effective management of waiting lists. I'm happy to take, I've tried to leave as much time so that I can take questions throughout, but we will, I know, speak about this again in the Oireachtas Committee, I hope, very shortly.
Minister